Top Bed Talk.
I'm delighted to introduce Jugdeep Dhesi, a friend and a colleague here in her CPOC role. So Jugdeep, can you introduce yourself and tell us a little bit about CPOC, and then we'll kick off with the session.
So yes, I'm here as Deputy Director at the Centre for Perioperative Care, which has been established for coming up to 2 years now, a cross-organisation collaboration, really kind of aligning professionals to the whole of the perioperative pathway, from the contemplation of surgery through to recovery from surgery. So bringing together a whole load of people from community, primary care, secondary care services, as well as social care and the third sector, to try to see how we can improve care for all of our patients undergoing surgery, whether that's the low risk, high volume group, or whether it's the more complex, smaller volume group. And really for this next hour, we're going to be focusing much more on that high risk group, and particularly patients living with frailty. And of course, for me as a geriatrician, that's particularly close to my heart. I have my role at CPOC, but I'm also Vice President at the British Geriatric Society. So it's a really exciting opportunity to start to align perioperative care with the British Geriatric Society and all of those affiliated organisations to try to improve outcomes for our frail older population. So that's why we thought it'd be really exciting to use this opportunity this next hour to discuss this important group of patients and what we're doing across the organisations to try to improve care, but also to be hearing from patients and from other allied health professionals along that pathway to see kind of what they're thinking in terms of delivering improved outcomes for frail people. So we've got 4 speakers. First, I'd like to welcome Jude, who is actually a colleague here at Guy's and St Thomas's, where I also work.
So as Jugdeep says, I'm a geriatrician at Guy's and St Thomas's, working for the POP service, the Perioperative Medicine for Older People Undergoing Surgery service. And I'm also the chair of the British Geriatric Society Perioperative Medicine Specialist Interest Group.
We've been working together now with CPOC and the British Geriatric Society at developing a new guideline.
Yes, so we've been working on a guideline for the perioperative care of people living with frailty. There is, of course, a real need for a cross-organisation guideline such as this. And we know that from literature published by Alex Fowler and Rupert Pearce that it's estimated that by 2030, there are going to be nearly 1.5 million people aged 75 or older having surgery annually in the UK. We don't know at scale how many of that group are actually living with frailty, but we can assume, given that we know that 1 in 4 people over the age of 85 years are living with frailty, that a fairly considerable amount of that patient group will actually have frailty. And we know, of course, and we've seen in the literature over the last 10 years that frailty and perioperative outcomes are adversely linked, so that people with frailty who have a surgical procedure are more likely to have increased mortality rate and more likely to have post-operative complications. So traditional clinician-reported outcomes are worse for a frailer group of patients having surgery. But we also see that patient-reported outcomes in people living with frailty who have surgery also tend to be less favourable. So things such as a poor return to their functional baseline, or having to go and live in a different environment, perhaps not returning to their own homes. And of course, we know that that also has impact on process measures. So things such as spending a long time in hospital after a surgical procedure, or the cost implication, meaning that we have less efficient, less well-costed services. So given that we think this is a numerically significant group and that we know we're seeing adverse outcomes, we really felt there was a need to develop a guideline to try and improve the care for this group of patients. I think as well, the kind of challenge of COVID is worth embracing here. So we know that there's been a lot of talk appropriately about using the waiting list as a preparation list. And so we were keen that the sort of estimated 5 million patients who are now on our surgical waiting list are actually provided with the optimum care that we can give them as we recover from the pandemic and resume usual surgical services. And so it was really born from these kinds of numbers and conversations that we decided to work across organisations to produce this guideline.
And when you say across organisations, what kinds of groups of people have been involved in the guideline?
The guideline is being co-written by the British Geriatric Society and the Centre for Perioperative Care, CPOC. But I think we were very aware in doing that we needed a whole pathway approach for older people living with frailty having surgery, and very much recognising that often the hospital admission, where the patient has their preoperative assessment, their operation, and then their post-operative critical care and ward management, really often represents a short punctuation in that patient's journey of care, often long-term disease management, the majority of which is done actually by primary care colleagues. So I think we were very keen in writing this that we reflected the whole pathway. So having engaged the boards at CPOC and the BGS, we then invited a very wide group of collaborators and co-authors, so really to try and represent that. So first of all, with the patient voice, with strong patient advocacy, and we'll hear from Lawrence in a while, but also with colleagues from primary care, from anaesthetics, from surgery, from critical care, from palliative care, and then with other disciplines and other specialties. So strong therapy input, with pharmacy involvement, with the involvement of ODPs and theatre staff. And so really trying to work across the pathway, involving all professional stakeholders and their representing organisations.
Sounds like Mike's got a question about that.
So I've got a couple of questions. The first one, should we be routinely screening for cognitive impairment, and what scoring system do you use?
I mean, there's been recent guidance published on this in the BJA from Carol Peden and colleagues. And I think really, yes, we are moving towards in a patient population who may be at risk screening for cognitive impairment. The environment in which you're working will affect the tool which you choose. In the POP service at Guy's and St Thomas's, we use a clock face as part of the Edmonton Frail scale that we do. And then we would do a short cognitive assessment using a Montreal cognitive assessment. So that's the one that we use locally.
And then as a second question is how does frailty overlap with concepts such as sarcopenia or deconditioning?
Cachexia, sarcopenia and frailty, and of course then fitness or deconditioning, are very much interlinked concepts. And sort of disentangling them is often very difficult in an older multimorbid patient who frequently, for many reasons, hasn't been able to get out and exercise, is vitamin D deficient, may well be sarcopenic. So it's important to remember that they are probably discrete constructs still in terms of academic literature and research. But in terms of our clinical services, we're very commonly going to be seeing patients who have all of those things overlapping and feeding into it. And that very much means that we need a kind of multi-component approach to managing them. And so as geriatricians, and we have an increasing evidence base for the use of comprehensive geriatric assessment and optimization in the perioperative setting, which is a holistic, multi-dimensional process whereby all of those things are kind of appraised and then hopefully optimized or treated in order to improve outcomes for a patient who often has that combination of cachexia, sarcopenia, multimorbidity and frailty.
But Jude, I think one of the other things you did just mention there was that interface with multimorbidity. And that's often a challenge to us in the clinical setting as well, isn't it? Is how much of what we do is managing multimorbidity and how much of it is kind of true frailty.
Yeah, so I think it's an interesting overlap because it's not actually something we've explored particularly thoroughly in the literature yet. So multimorbidity defined by NICE as two or more coexistent conditions, and then frailty, which we know has a separate definition, so a vulnerability in an often older person to minor external stressors. We think from the literature at the moment that there is overlap, but they remain discrete constructs. So we would think that in frail patients, about 7 out of 10 of them probably are also living with multimorbidity. Whereas if you take patients with multimorbidity, only about 2 out of 10 of them are probably also frail. But this isn't something that we particularly understand well at scale yet. And the SNAP-3 RCOA-funded national audit, which is due to be going ahead in autumn, will hopefully help us understand this a little more, because we're at scale going to be looking at how common frailty and multimorbidity are in an older patient group undergoing surgery.
Thanks, Jude. What I'm going to do at this stage is bring Lawrence in. Again, I'm going to let Lawrence introduce himself.
Thank you very much, Jugdeep. Really wonderful to be here. I was just saying to myself, really, that EBPOM, CPOC really value the voice of a patient, and so what a pleasure it is to actually be part of this talk today. I'm a patient representative for CPOC board. I've had a healthcare background in dentistry. I moved from a healthcare provider to a healthcare receiver following a diagnosis of cancer a few years ago. And here I am 4 years on and a successful outcome later. I say we all like a really good KPI, don't we? I've repositioned myself now as I've retired from frontline healthcare to inputting a patient representative perspective in healthcare. So the main areas that I'm involved with are shared decision making. Jude mentioned it earlier, moving away from an idea of a waiting time to go into a preparation time, getting patients better and fitter before they go to surgery. And also this guideline on frailty.
Thank you, Lawrence. I think lots of people might sit in an audience such as this and say, well, kind of, Lawrence, you're not particularly frail, and kind of looking at you, and you're probably not in the socioeconomic class in which we see most of our multimorbidity and frailty. And so kind of as a challenge back, how do we make sure that we're reflecting the views of patients who are frail, older, and the predominant users of our healthcare systems? So straight in there, kind of posing a difficult question for you, Lawrence.
It's a great question, because actually it sums up an awful lot of the concept of frailty, doesn't it? So frailty is all about a strong indicator that as you get older and you have more illnesses, you're more likely to go down a pathway where you take a fall, you're hospitalized, you move from an independent to a dependent person. And that's really quite a big thing for an older person. And we also know that the socioeconomic side, which you were mentioning, is very strong. We have more people from a poorer background, from certain cultural backgrounds, ethnic communities, who seem to be much more prone to frailty. So I think we have to look at it and say there's an awful lot of factors that come in here. Yes, it's about being a bit older. Maybe if you're female, you have a higher chance of coming along. But it actually goes back even further, doesn't it? It actually starts in childhood, because the deprivations that you may well see in childhood of poor education quality, poor food and nutrition, stay with you right the way through the whole of your life. So the whole of frailty isn't just tied up, I feel, in being an older patient. It's a whole life experience. And I suppose these guidelines are great for me because they look at how to look after somebody in a certain situation when they're much older. But if you roll back the clock, wouldn't it be wonderful if we could catch all of these areas at a much earlier age, and we can get predictors for frailty at a much earlier stage of life. So Jude, you're talking very much there about the opportunities for further research. Here's a wonderful opportunity to go back in time almost, to make sure that the new generation of patients who are going to be frail later on in their lives are actually much better prepared for it when they get there. So it's taking all the evidence we have, and there's an awful lot of it out there, but there are gaps in our understanding of frailty and how it actually happens. Jude alluded to COVID. You know, what a great illustration, very tragically, of those who weren't able to look after themselves as well succumb to COVID. Many of us probably can't even remember back 14 months ago of the fear, the anxiety that patients actually had. We're living in a new norm at this particular stage. So frailty, if you like, can captivate so many different parts of the whole life journey of an actual patient.
Can I just ask, sorry to jump in, Jugdeep, I just you're a very well-informed patient, as the reasons that you just described to us, but the concepts of frailty, and Jude touched on the notion of resilience in her talk, and I think you mentioned it in yours. Is that just us talking to ourselves, or are those framings that have traction in general outside of a sort of specialist conversation?
They definitely do. So one of the things I've recognised about frailty is it's incredibly misunderstood by patients, their families, their carers. It comes as a shock to people because you get a stressor event perhaps, and suddenly you're told you're actually frail. That's a really big thing for patients. And let's be honest, I'm a professional patient representative, if you like. I've had a professional healthcare background. How am I going to actually go out and actually speak to those people in different social economic groups to actually get the same message across? How am I going to do the same with health literacy, which we know from research could be a aimed at a 9 or 11-year-old. All these things are incredibly difficult factors to actually do. One of my roles previously was actually as a council member for the General Dental Council, the equivalent to the GMC. We actually had a fantastic patient group, if you like, a tame patient group of about 5,000 patients, all from different economic backgrounds, all different backgrounds where we could test some of the theories we had. Wouldn't it be fantastic? Maybe this is a plug for CPOC while it comes off the top of my head now, to have a group of patients like that we had as a representative of the whole of the United Kingdom, all 4 countries, so that we can dip into that and say to 300 patients, 1,000 patients, how does this guidance, how does this information impact you? And actually then break it down to social economic areas. Perhaps that's another area, Jugdeep, that we need to look at and say, do we need a tame patient base? Not just somebody like myself who can put on a tie and shirt and present at EBPOM.
There's always challenges at CPOC, aren't there? Continuing kind of lots of work to be done. But that is a really important point, isn't it, around how do we engage with the wider public and the main users of our healthcare systems. And at the moment, another plug for CPOC is that we are conducting a survey with patients, looking at their thoughts and views on the perioperative pathway. And our concern with that survey at the moment is that, again, it will be filled out by people of particular social groups, particular backgrounds. And it's about how we as a community make sure that we are giving out that survey to all of our patients who attend a clinic. And so an example so some of the units which are doing the survey have now decided that they're just going to give it to a consecutive sample in one clinic in 1 week, so that then at least they get 20 or 30 patients who may be more reflective of our population, rather than trying to send it out through electronic apps and so on as well. But Lawrence, you raised a really important issue around health literacy, e-health literacy, the use of digital tools as well.
Yeah, I think, again, in some ways, as part of COVID recovery, we've seen an awful lot of digital innovation. So the use of iPads for patients talking to their families in critical care, a lot of work such as things like Prep Well, trying to get patients as fit as they can be before surgery, and kind of innovative use of technology for a possibly unfit patient group, particularly with COVID-related deconditioning. But what we don't understand is how well our often older and frailer patient group, so often the high-risk surgical group, can interact and interface with these kinds of digital technologies. And as we've alluded to, that comes partly from general health literacy. It comes also from e-health literacy, but also that we don't have a full understanding of the kinds of attitudes and approach that older, frailer patients have to using apps and things. And we can all think of examples of clinics we've done where you say, oh, it's okay, the hospital will text you with the appointment, and someone scrabbles around in their bag and pulls out a Nokia 3210, which hasn't been switched on for 5 years. And so there is, whilst we see that anecdotally, what we're keen to do is kind of understand that in a more structured way. And so we're putting together a bit, again, jointly with support from CPOC and the BGS to try and look at that in the research setting. So that will hopefully be interesting work to kind of inform these pathways as we move on.
Thanks, Jude. I'm really impressed with you knowing the different numbers of Nokia phones. I would have just stopped at the Nokia stage as opposed to the actual model. So that's
my first impressive. Mobile.
So I'd like to bring in Jessie now. Jessie is a general practitioner, and that's probably a really opportune kind of moment to bring Jessie in around health literacy and the issues that are encountered in this population, particularly when they're first being referred into the perioperative pathway. So Jessie, do you want to introduce yourself and maybe some reflections on what you've heard so far?
It's great to be here. Thank you so much for letting me come. I feel like it's been a real journey since working with Jude and Jugdeep on the survey that we've done, which I'll talk about in a second. So I'm an ST3 GP registrar in South Lewisham. And I think certainly talking about technology, we've seen a huge change in how we practice in primary care, transforming the way that we contact patients, the way that we consult. And certainly we've seen that frailer and older population have suffered potentially more, because often at least all we have access to on our records is a landline. Often they don't necessarily feel comfortable using their phone. It's a real challenge. I think we're also worried about this kind of unknown 6 million missing patients that we know about that haven't come forward for surgical referrals. And we're kind of just, waiting for people to come forward to see what happens. And I think it's a really exciting time, certainly looking at perioperative medicine within primary care, because the values align a lot with what we should be doing and what we are already doing in terms of trying to have proactive rather than reactive care, in terms of trying to optimize long-term conditions, and also in recognizing frailty. There's a huge lot of work to be done in how we recognize frailty in primary care, how we communicate that to our colleagues working in the community with us. And in secondary care, we generally use the electronic frailty index a lot. It's something that is already populated within EMIS, which is the program that most general practices use, but it's not very well understood. It's actually quite new. There's not much training on it within GP. It's something that there's so much work to be done there, really.
And there has been lots of work that you and the team have been doing through the BGSGP group as well. It's starting to promote this type of work. Do you want to talk a little bit about that, Jessie, and some of the initiatives which are coming out in primary care?
Yeah, certainly. So I'm also a member of the GP BGS group on the committee. So we're trying to find ways of improving education and improving our understanding and recognition of frailty. So there's excellent BGS modules on how to recognise frailty, which I know you've mentioned in the guidelines that you're writing at the moment in that draft. One of the problems I think that we saw with the survey that we did, but also working as a group of GPs across the country, is that our approach is so different, and that's one of the big challenges. So it doesn't necessarily have a one-size-fits-all approach. We have different screening tools in different areas. Even just between Lewisham and Greenwich, we have different ways of recognising frailty and referring onto frailty hubs. So certainly, I know that David Atwood in the BGS is a great advocate for joined up technology and a more transparent way of working to improve communication between primary and secondary care. And that's hugely important and something that we struggle with a lot. And I think something that we saw in our survey that we did, that one of the things time and again that came up was that lack of communication between primary and secondary care in being able to move forward to improve patient care.
Mike.
There's been a real flurry of questions. First one, which got a lot of votes. What, in your opinion, would be a quick and succinct screening tool for frailty in the preoperative setting?
So I think probably for Jude.
So we would advocate the clinical frailty scale based on Rockwood's frailty index, which is a pictorial scale, can be done by anybody, takes a couple of minutes.
So if they choose something else, how bad is that? Because there's a spectrum of things around. Have they ruined their screening programme, or what other opportunities elsewhere?
So I think that we have, as we've understood more about frailty over the last 20 years or so, had lots of discussion around screening tools. But I think you can always argue one tool over another and the properties of one tool over another. But essentially, we need something that's pragmatic and could be consistently embedded regardless of the circumstance. And so, or the clinical scenario. And so I think we do really see now from our national frailty networks, and also we will be seeing in the frailty guideline that we're discussing today, that CFS is the tool which is advocated. It doesn't involve training, it's free to use, and a score of 5+ would indicate that a patient should then be referred to frailty type services. I suppose it's worth just mentioning that doesn't negate the work that Andy Clegg and his group have been doing with the electronic frailty index, which Jessie mentions, which is a very good frailty score which can be derived from routinely collected GP data, and which certainly maps very cleanly on to other models of frailty as first described. And I think, as you mentioned, Jessie, as we get training underway and people are really on board with that, that may well be a useful adjunct. And we may find that patients are presenting to all of our services with a frailty score already done as per the EFI. But whilst we're in this kind of interim stage, a quick and easy CFS is the tool that we'll be advocating. You
may have already answered this because you've touched on the issue already, but is there a frailty scoring system in the primary care that can be utilised in secondary care for patients that are planning for surgery? Same answer? Yeah.
So Jessie, do you want to reflect on that?
Yeah, so certainly we now, as a routine within primary care, as far as I understand, across the UK now use the EFI. the information, as Jude mentioned, that the scoring is only as good as the information that we have available. So it's not a perfect system. And I think it was designed to be a screen rather than an actual way of diagnosing frailty. So it's only good if you then are able to look at the patient once you know them and say, do I see that this patient really is as they appear on their scale? I think it has weaknesses in that it may overdo how frail the score is if they've got many multimorbidities. And equally, it might not get those housebound patients who don't necessarily attend for things and are having falls at home, but don't have the diagnosis of, say, COPD or ischemic heart disease or anemia. So it's what we have for now, and it's good that it's very automatic, it's quick, and it's something that doesn't require any extra work. But I think I like Rockwood, and I know that lots of my colleagues who are familiar with frailty within primary care also like to use the Rockwood clinical frailty scale to go forward and just to validate the EFI.
So is there a self-screening tool for frailty? Is there any sort of online system that people can do for themselves?
So anybody kind of want to volunteer for that one? Jude, do you want to take that one?
I don't know of a patient completed validated score, no.
No, so I don't either. Yeah.
The only thing I've heard of is in Lewisham A&E, one of our frailty practitioners is just writing up some evidence about people who are able to fill out a questionnaire that would be part of a self-assessment CGA. So for younger patients who are able to fill out the questionnaire, and they're just kind of looking at whether that's, I don't know whether that's something that other people have come across, but I guess that would be useful and time efficient if someone is able to fill out their own questionnaire. And
a couple of quick fires, then I'll park the others, give you a chance to chat again and come back with them. Is there a screening tool you'd recommend for sarcopenia or sarcopenic obesity?
We use SARC-F for diagnosis of sarcopenia.
Do you think the Mini-Cog is a useful starting screening tool for cognitive impairment?
Yes, so it is advocated by lots of groups, and 4AT is another tool which is sort of gaining in popularity, and lots of services, perioperative services actually are using it. So there are lots of these tools, for brief cognitive assessment.
And I think what that kind of really also illustrates is that importance of getting screening in, whether it's for physical frailty, cognitive frailty. And although we are trying to push for a standardized approach for that, just so that it makes it easy and more consistent and allows data gathering, at the same time, there's no reason why people shouldn't use other validated tools as long as they are validated and they are measuring what we think they're measuring. And that's been one of the issues in some of the frailty tools which have come out, is that actually they've not been looking at frailty, they've been looking at multimorbidity. So you do have to be careful about the choice. One of the things that we are trying to do through the guideline is give some really clear direction on this. And so we are advocating specific tools so that it, avoids this continuous conversation about which one should we use, shouldn't we use, whilst trying not to be too prescriptive as well. So it's that kind of fine balance, isn't it, between the two issues. And I suppose that lends kind of really nicely to bringing Liz in, because of course, once you've screened for frailty, or even if you've diagnosed it, the next question is, what can you actually do about it? And there are probably lots of things that we can do kind of from people who are specialists within the field of frailty and geriatric medicine, whether that's in primary care or in secondary care. But what do you do when you don't have geriatricians and you're trying to do this in the perioperative pathway and trying to establish new services for people living with frailty? So Liz, would you like to introduce yourself and kind of talk about interventions and kind of how we can start to embed pathways of care for people living with frailty?
So my name's Liz Huddlestone. I'm an anaesthetic consultant and the clinical lead for pre-op on Wirral. I think that is a really big question, isn't it? And it's when we started our POPs network involvement, that was my concern, is that we can measure for frailty in pre-op, but what are we going to then do with the patients who we've identified as being frail? 10% of our patients undergoing surgery are over the age of 80. We're hoping to start with the elective colorectal group, and in that group, 50% of patients are over the age of 60. So there is a need, and we've known about that need for some time. We have one PA of geriatrician time, but her time is focused on looking at after the NELA patients post-operatively, and everybody else's job plans are full. So whilst we all recognise that there is a need for onward referral, and whilst we long-term build a business case towards that, one of the things that our involvement with the POPs NHS Elect network has demonstrated to me is what we can actually do in the interim. And I think that anaesthetists do have a role within pre-op clinic. So one of the many things I've learned since we started last month was I went to the BGS website and looked at the comprehensive geriatric assessment. And actually that is something that has quite a lot of overlap with a consultant-led pre-op assessment. So, within that there's functional assessment, you're taking a social history and working out what people can do. You're speaking to them about what's important to them and actually what is it that affects their quality of life and how is that going to be affected longer term by having surgery. And that is all about shared decision making, isn't it? And identifying what's important to that patient. And there were other aspects that I've tried to incorporate into my pre-op assessment, looking at asking patients about mood, memory, bowels, bladder, things that I didn't ask before but are important. And obviously one of the biggest things to say is that I'm not an expert and I can't manage all of these things, but I can identify where the issues are, create a problem list, and actually just by communicating more and working together across divisions within Wirral University Teaching Hospital, I've come to learn of a lot more things that I can refer patients onto. And our Trust Clinical Frailty Lead, Dr. Chu, is very enthusiastic and is very keen to teach everybody about frailty. That's the first place we're going to start, is by asking her to teach us across the surgical division about why frailty is important, how we recognise it and what we do with those patients.
Thanks, Liz. And I think kind of some of the things that we've been talking about are some of the barriers and the challenges around establishing kind of services for people living with frailty. I think that'd be a really interesting thing to discuss here, because a lot of the audience are going to be anaesthetists or people working within anaesthetic departments. So it'd be good to hear your reflections on that.
So I think, like I said, everybody knows that this is the right thing to do, but there's such a big gap, isn't there, between identifying what you need to do and being able to go about doing it. And a lot of that is about building business cases and gaining funding, but some of it is about education and enabling people from the wider multidisciplinary team to have a role. So one of the things we've looked at is we've got a fantastic perioperative pharmacy team, and whether they could come work with us more because they do medicines reconciliation and give one-to-one advice, especially for those patients who do have perhaps a lower reading age or are unable to understand the leaflets. They ring them up and give them advice over the telephone. So that actually would be a good opportunity to look at medicines reconciliation in terms of polypharmacy, looking at anticholinergic load. So it's just trying to work differently whilst also building the business case by starting by gathering information. That's one of the things we talked about, wasn't it, our initial network visit, is how can you prove a case to the trust if you're not measuring how many frail patients you've got? You need numbers, don't you? So a good starting point is measuring frailty in the pre-op clinic. So we're redoing our pre-op electronic assessment in line with the CPOCs pre-assessment guidance that came out this week. And as part of that, we will be looking at clinical frailty score in patients over the age of 65. And then longer term, as you suggested, those with a score, a CFS score of more than 5 will need an onward referral pathway, but that's not something we're going into this being able to achieve. So I think the first step protocol for those will be they will come to see us in the consultant clinic, and then working with my geriatrician colleagues, I'm more aware of things in the community we can refer into. So looking at rehabilitation at home, we can refer into that. And also we have nurse practitioners for older people who, having done a sort of mini CGA in pre-op clinic, I can refer on to them with a problem list, and then they can go and assess those patients.
Yeah, and I think that's been really interesting, kind of listening to your reflections today, but also previously as well, about how much actually already exists out there. And it's only once you start to make those connections that you can work out that actually we can link with such and such a service and they're able to do this, the pharmacists, the rehabilitation teams and how they interface within this, other therapy teams who exist in the community, the nurse practitioners. And often it's that coordinating role, isn't it, around utilising what already exists out there.
Going back to asking about the challenges, I think it is time. So we have meetings every 2 weeks as well as the network meetings, and not everyone can attend all of those meetings, obviously, because of clinical commitments. But one of the things COVID's given us is better IT, isn't it? So we use MS Teams, put files on there that people can share. If they're not able to attend the network meetings, we then get the slides and upload it to there. and we've used some of our documents that we can all edit. So one of the homework allocations was to do a driver diagram looking at what our aim is, how we break that down into actual tasks, and then what are we measuring. And obviously we're coming into that from very different aspects. So I'm an anaesthetist, there are geriatricians and surgeons, and everybody has different ideas. And that way, although we can't always meet in the same time, we can edit documents virtually.
And that has been an interesting process for me as well. I think with the NHS Select work, an arm of NHS England who is supporting with the scale up and rollout of services, what they've been able to do is give us a bit of an infrastructure, haven't they, to be able to work together to do this kind of work. It looks like Mike's got a question as well.
If a patient is identified as frail pre-elective surgery, is there a system in place to optimise or reverse the frailty prior to surgery? Will this likely lead to postponing surgery, allowing for individual circumstances?
Jude, maybe do you want to take that?
So I suppose just to use the opportunity to say that we're very cognizant with this guideline that this doesn't want to be a kind of gold standard set up there for other services or other hospitals to feel that they are never going to be able to attain to. And so I think whilst we are being clear, hopefully, and in the standards, that is slightly aspirational at this stage, because we know that not everybody has a fully fledged frailty perioperative service, and that there aren't enough geriatricians, and that we're working through those workforce issues sort of locally and nationally at the moment. So I think, Liz, you described really nicely the other things that go alongside the guideline, like training and upskilling and accessing other services, so that whilst we do want to have gold standards in our guideline, it's to sort of encourage trusts and support trusts to be able to attain to that in time. It's not something that people are going to have to achieve by next year. So I think that's kind of important to say for when the guideline comes out. In terms of the preoperative assessment and management of frailty, I mean, I think we have good evidence now for comprehensive geriatric assessment and optimisation as the gold standard for both diagnosing frailty, but also for optimising it. And we've got an evidence base in community settings that patients who undergo CGA are more likely to be alive and living in their own homes at a relatively good level of independence at sort of 6 to 18 months after that CGA process. So we have good Cochrane level data on that in community settings. That literature has been translated into the perioperative setting to some degree, both electively with some of the work we've done at Guy's and St Thomas's, looking at preoperative CGA and having an impact on postoperative outcomes. So patients who had CGA before vascular surgery had a shorter length of hospital stay due to fewer medical complications. We have cost-effective data showing that actually that process of CGA was cost-effective for the trust, predominantly through bed days saved. And we also have evidence for CGA in the emergency surgical group, even though it's far more complicated and messy with timelines to surgery. But we know from the orthogeriatric literature, where urgency of surgery is obviously paramount, that there's again Cochrane level data that CGA employed by a geriatric medicine-led team does lead to reduced mortality rates with a health economic argument behind it. So yes, I think we have an argument for CGA, but implementing that is where the kind of interesting bit comes and where the challenges are.
Thanks.
And I've got a more anaesthetic question, which would it be right to say that there are limited additional things on the anaesthetic side we can do to prevent POCD, postoperative cognitive dysfunction, given best anaesthetic care, i.e. usage of intraop EEG, adequate pain control, multimodal analgesia, already aimed to prevent POCD? Question.
Liz, do you want to reflect on that?
I think it's about that MDT input, isn't it? So just being aware when we prescribe opiates that it's more likely to cause constipation, and having that is actually really important, and using laxatives and maintaining hydration and trying to maintain mobility and do day case surgery, all the things that we sort of already know. I don't have any clever answers than that, just doing simple things well and keeping a closer eye on these patients, and ideally having, geriatric assessment on the ward afterwards, whether that's AMP, triaging to a consultant, or whatever form. That would be my answer.
Well, I was going to bring Lawrence in, because I think we can go down the route of lots of kind of very specific questions. But I think one of the issues that Liz raised there was that how this informs shared decision making, and that being such a big issue for this particular group of patients. And of course, Lawrence has a wealth of experience in shared decision making.
So many patients have a view of the outcome for the surgery they've actually had. And sadly, in a number of cases, the outcome isn't what they expected. The outcome has changed their quality of life. And of course, with frail patients, that's an even bigger problem, because actually you go from an independent person to a very dependent person. And I don't think, from a lot of the discussions I have with patient groups, there's enough understanding, I suppose, about what frailty actually is. And I think probably there's still this negativity around frailty as well in an older person. So there's a lot of communication to be had, I think, before we even get to the shared decision-making stages of actually unpacking to a patient exactly what the options are. So we talk about brand, don't we, quite a lot, benefits, risks, alternatives, doing nothing. Those type of areas, I think, are going to become increasingly important. And I suppose, whilst I'm excited that hospitals are starting up operations now, I'm also concerned at the same time that there are many patients who may go through surgery quite quickly without a shared decision-making process taking place. Now, if you add on to that the numbers that we were hearing, 10% of patients with frailty in the Wirral, then suddenly you have an awful lot of patients who might actually have regrets of the outcome of the treatment they actually have. So I think shared decision-making is going to become not just the latest buzzword, but something that we need to get right at this stage before all those operations take place.
That's often the real challenge, isn't it, in this group of patients, because when you're talking through the benefits and the risks, often the risks are not directly the surgical risks, but the risks related to people's other underlying health issues, whether that's changing the trajectory of an underlying comorbidity, or whether it's that functional change, whether it's cognitive change. And those are the kinds of things that actually for our surgical colleagues are very difficult to be able to go into detail when they're taking consent as well. And so it all kind of feeds into that kind of issue, doesn't it, around then the legality of consent documents. Are they actually reflecting the risks that are important to the patient?
Can I just lead on for that for just a moment, Jugdeep, because of course the recording of that is so important as well. And I know that the Professional Standards Records Body are currently developing a shared decision-making generic guidance. And that's a lovely way of moving forward in this particular area, because it's not about consent, but it is about all of the important information that needs to be recorded on behalf of that patient so that consent can actually take place.
And certainly locally, that's what we've also been talking about, is how shared decision making starts out in primary care with the general practitioner when they're first making that referral. Because of course, that's when you start to talk about the benefits of potentially being referred in. And so it's actually a process, isn't it, that continues along that perioperative pathway and then culminates in a final document at the end of that. But you need documentation along the way as well. And that's where all of this becomes very challenging.
When we were looking at GPs' confidence in shared decision making at that very early stage of referral, I think one of the things that people struggled with from the survey, from the open comments, and also from our very specific questions we ask people, is the alternatives part of the kind of brand process. That I think that's an area that general practice finds very difficult, because we don't know what the alternatives are. The types of surgery we refer patients to is as diverse and wonderful as our patient group itself. So I think that's a really difficult thing to talk about. And I think also people found that they didn't discuss the doing nothing thing. That was the thing that I think is discussed least, perhaps, certainly in primary care, when we're going forward with that shared decision making from the beginning.
Would you say that one of the most important parts of measuring frailty is to inform a risk discussion with the patient early on?
Jessie, do you want to go first?
Yeah, so I certainly think that is key, isn't it, at the very beginning. And I think there's a real confusion in primary care maybe about the primary care role in that, but that's certainly, and I think there's a bit of anxiety about saying in a very informed, up-to-date way, these are the risks, these are the benefits. Certainly that's a discussion that needs to start from the very moment that someone says, I think I need surgery, or that you're suggesting that, there's a surgical outcome that could benefit them.
And Liz, anything to add to that?
That's absolutely right. And that's one of the reasons why, in the absence of a referral pathway at the moment, we will be seeing those patients in pre-op clinic to have that discussion. And it comes back to asking patients, what is the symptom that bothers you? And often it isn't what they think they're having surgery for, or not often. Sometimes it's discussing what the risks are pertinent to them. And obviously, the more information you have about the patient, including the frailty, the better that conversation is.
Again, from across the country where there are perioperative services for older people, we're finding about between 15 to 20% of patients referred in don't end up choosing to go ahead with the procedure that they initially thought that they were going to have. And so it's those kinds of figures, which is a pretty big proportion, isn't it? 1 in 5 roughly coming in saying, actually, this isn't the right thing for me. So Mike, you've got some more questions.
Yeah, one of them was, is prehabilitation a treatment for frailty? And then a slightly more challenging framing, how does CGA differ from comprehensive prehabilitation program apart from being delivered by a geriatrician? And there is a name attached, but as it's challenging, I won't quote it.
So I think maybe, Jude, we've let you be quiet for a little bit. So do you want to take that one, the interface between prehab and CGA?
Yes, I mean, that's a great question. And I think if we go back to what CGA is, it's a multi-domain assessment and a multi-domain intervention. And so what that means is that whilst as the physician, I might well be optimising their heart failure medicines or treating their anemia or optimising their diabetes, we very much work in a multidisciplinary team where our therapy colleagues will be involved in setting exercise targets, prescribing exercise, and prehabilitating or rehabilitating that patient depending on where in the pathway they are. And I mean, that's very true to the original description of CGA. It was multidisciplinary and it has always involved a multi-domain approach, not just exercise, but also optimization of nutrition, and then involving occupational therapists to optimize the patient's home so that actually they're not disabled by their home environment. So yes, sort of prehabilitation or rehabilitation has always been part of CGA. And of course that fits with our frailty literature, because we know that CGA works for frailty, and we know that the main modifier of frailty is protein supplementation and exercise. So it kind of hangs together as a multi-domain intervention.
So I suppose just to kind of close, I think it may be useful just having very short reflections from each of the panels as to anybody who's listening into this, if there's one thing that they're going to go off and do today or tomorrow, what would you advise people listening in to go off and do tomorrow? Jude, do you want to go first?
Look out for SNAP-3, look out for the guideline and embed it, but don't worry about being too purist. And anaesthetists and geriatricians and surgeons should be talking to each other.
Liz, would you like to go next?
Just try and learn as much as you can. So there's great resources online, and I agree that the geriatricians within your hospital are the best place to start, because then they can tell you what you can access and maybe organise some education for the wider surgical team.
Yeah, it's using those resources which already exist, isn't it? It's kind of amazing how not everybody knows that they're out there. Jessie?
It doesn't matter what frailty tool you use, as long as you're thinking about frailty and assessing it. And like Liz said, just keep improving. We can always improve on our CGA. And if you feel that you're out of your comfort zone, then ask someone else, because someone else will know, whether that's mood or continence or managing their bowel. So you can't do it alone.
Yeah. And I think for me with primary care, it's kind of picking up the phone to you guys, because it's amazing how quickly you can sort out these things once we all talk to each other, rather than leaving it to letters and other people to make that communication. And Lawrence?
I think I'd just give you one phrase, and that would be opportunities. So you talked quite a lot earlier on about education of clinicians and healthcare professionals. I think we all have an onus on educating the general public and patients as well. Just having a badge, a label of frailty, which in older people's minds is a negative thing quite often. There's an awful lot of positivity in there as well. For example, you might have a severe frailty case, and maybe 6 out of 10 are not going to make it for 5 years. But guess what? 4 out of 10 are. It's not a death sentence. It's something which we should be looking at very positively as well.
So that's a great note on which to end this session. As usual, Lawrence is definitely half full, and a positive note to end on. So thank you for that, Lawrence. And thank you to everybody on the panel. It's been a really great discussion and hopefully answered lots of questions out there, but also generated lots more discussion and more questions that we can all then start to work together at addressing. So thank you, everyone.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.